All right, and that is all for eyes. On to the ears. Last section. Let's do it. Okay, so sound comes in. You get all these pressure waves. Goes through your outer ear, middle ear. Goes these ossicle bones. It's going to cause fluid to go through the cochlea. That gets picked up by cranial nerve 8, the vestibulocochlear. This goes to the medial longitudinal medial geniculate nucleus, which goes to the inferior colliculi, which then goes to the auditory cortex in the temporal region. Typically, though, it's going to go contralaterally, though. So the right ear will go to the left side of the brain for processing. So again, we have our outer ear here. Your ear is an auricle, also known as the pinna. We're then going to go through the external auditory canal. We have the tympanic membrane. Now we're in the inner ear. In the inner ear, we have these three auditory muscles, the malleus, the incus, and the stapes. They are going to rhythmically contract. They're going to push on this oval window of the cochlea. That's going to cause fluid to move through this snail-like structure of the cochlea, and it's going to be exciting hair cells that goes through. This is the inner ear here in blue, also known as the labyrinth, because it does kind of look like a maze, right? It looks really complicated, right? Thinking of like the Minotaur of Greek mythology and Theseus. So yeah, it will be hearing and balance. We'll talk about both of them. Hearing first. So sound waves come in. They're going to pump, 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 move all of this. This is going to push on this window here, and then it's going to cause fluid to oscillate through. So we have perilymph and endolymph, and I think they're both moving. I'm a little fuzzy on that, but it's going to move through, and it's going to stimulate this organ of Corti, which sits on the basilar membrane. This has hair cells, which are just going to sort of respond, to the changes in current of the fluid of the endolymph. I would note though for the middle ear that the stapedius cranial nerve 7 is going to help regulate the stapes, and so if you have a Bell's palsy or probably just a Bell's palsy, maybe a stroke, and you don't have innervation here, then you're going to get hyperacusis. Things are going to seem really loud that really aren't that loud. All right, so this is an ugly slide. There's way too much going on here, but whether you want to, I would know that the base is the beginning of the cochlea, the apex is the end. And at the beginning, we respond to high frequency sounds. At the end, we respond to low frequency sounds. We kind of see the same thing here, is that low frequency sounds reach the end, high frequency sounds stimulate the beginning. Fluid is moving through here in the endolymph, and here we have the perilymph on either side of it. And you can just think of, all of these people are hair cells, the organ of Corti, the basilar membrane, and this is the endolymph responding to fluid, and boom, it's going to stimulate all of these things. All right, so hearing loss can be conductive. The nerve impulse just isn't working. This, for the most part, means that we have an inner ear issue. And it can also be, it can be sensory neural, is everything I just said. Conductive is going to be the opposite. Conductive is that there's like a blockage, there's an obstruction. That's going to be the outer ear or the middle ear. So conductive, blocking, outer, inner, sensory neural, nerve, it's going to be the inner ear. Presbycusis. So Presbyterian, this is elders, this is old people, so natural age-related hearing loss. You can lose your hearing more quickly if you go to loud concerts and listen to loud noises, or a construction worker. This is going to, accelerate the presbycusis. Typically, people are going to lose higher frequency hearing first. So I had a physics professor and teacher in high school. He was also the wrestling coach, and I wrestled. So, we'd always mess with him. And he worked as a construction worker when he was younger, and he was old. He had terrible hearing, especially his higher frequency. So in the middle of class, we'd sit at the back, and we would just go beep. We'd just make really high frequency sounds to see if he could hear it. And a lot of times he could hear it. He'd get pissed. Notice that if you listen to really loud noises as well, that this can also bust the tympanic membrane, which is, this is all sensory neural, but busting the tympanic membrane is going to be obstructive. An acoustic, so lots of tumors we could have. Probably the main one is going to be the acoustic neuroma associated with neurofibromatosis type 2 on chromosome 22. And this is just going to press on the sensory neural, the vestibulocochlear nerve. It's going to have maybe a lot of similar symptoms that we would have if we had like a Wallenberg syndrome. Speaking of which, Wallenberg is going to be, maybe it could also be an ACA symptoms as well. Depends how big of the tumor is and where exactly it is. But so AICA is going to be the lateral pons, And remember, rule of 4 is cranial nerve 8 is supposed to be in the lateral pons, but it's kind of tricky. It's also a little bit in the medulla as well. It's kind of like, it's got a foot in both camps. Interestingly, if you had 100 AICA strokes, this is going to affect hearing more often than if, let's just make up a number. 80 of the 100 AICA strokes will affect hearing. However, the much more common PICA stroke, the Wallenberg stroke, this is now a little bit inferior, the lateral medullary. If you had 100 strokes, maybe now this is going to be like 40 of those will have hearing issues. But keep in mind that the peak of the Wallenberg stroke is more common than the AICA stroke. So I don't know. I would just look out for it in both of these. Both of them theoretically could cause sensory neural hearing loss. Earwax, this is just going to be obstructive. You got too much wax in, sound has a hard time getting through. Drugs, especially cisplatin, this is ototoxicity. This is going to damage the cranial nerve 8, so this is sensory neural hearing loss. If you go swimming, you get fluid that collects in your ear, and that's just a breeding ground, like a little petri dish for bacteria and viruses to proliferate and cause an infection. Or if you just have an upper respiratory tract infection, there's this eustachian tube that connects the upper respiratory tract with the ear canal. And so you could have an infection travel up through here and get to your ear. So that actually happened for me in the last few days. I had like a cough like a week and a half ago, and then it went to my ear, and it was terrible. If you do swim, you can take ear drops, which are really just isopropyl alcohol. So how does this work? There's a lot of hydrogen bonding, which keeps fluid together. So if you get fluid in your ear, water has like a pretty high boiling point, so it doesn't vaporize that easily. So it's going to stay in your ear. Again, this is a breeding ground, a spawning ground for bacteria and viruses. Isopropyl alcohol, though, doesn't hydrogen bond as well as water does. For one, it's because per atomic mass, per number of atoms, there's not as much opportunity for hydrogen bonding, right? And this OH has one oxygen, 2 hydrogens. Each of them could hydrogen bond with something. This isopropyl alcohol just has one OH. So you could maybe have one with the oxygen, one with the hydrogen. You have to keep in mind as well that carbons are electron pushing. So this is partially negative. So this partial negative is going to maybe destabilize the hydrogen bonding. We also have to think about the fact that hydrogen bonds are directional. So they have to have a 180 degree angle. You can't have like 150, 120 degree angle. For all of these reasons, it doesn't really matter. Alcohol evaporates more easily. It's going to interfere with hydrogen bonding. So if you have fluid in your ear after you swim and you put in isopropyl alcohol, it helps evaporate all of that fluid so it leaves your ear so that there's less opportunity for bacteria and viruses to proliferate. Infections could go either way. So again, upper respiratory tract and swimming leads to infections. Now, are they sensory neural or are they conductive? They can do both. So if you have an inner ear infection, fluid can build up here, and this is otitis media. Could also be otis externa if it's in the ear canal over here. What about over here on this side? If we have an infection of the inner ear, you do not call this otitis interna. You call this labyrinthitis. It's also called vestibular neuritis, and it can affect hearing and it can affect the vestibular system. Kids often stick things in their ears. This can be an obstructive hearing loss. Adults as well. Earrings, especially older people with hearing aids, can get lost in the ears. We got a cool guy outside. All right. You could, people are trying to clean their ears. They can perforate their eardrum. Loud noises also can perforate an eardrum. Trauma. Okay, trauma, obviously if you get smacked in the ear, and I did a lot of wrestling, people get cauliflower ear. This can just damage directly physically the external ear and the middle ear. And but it could also, depending on how hard you get smacked, it could also damage the inner ear and the cause sensory neural hearing loss. So it actually could be either. It seems like it would just be conductive. It is both. All right, a little summary. Presbycusis, you're going to lose your hearing as you get older. Typically, this is going to be the higher frequency sounds first. This is sensory neural. Tumors are probably going to press the cranial nerve 8. That is going to be sensory neural. Strokes are probably going to be, you get your pica, aica, your Wallenberg strokes. This is going to be more the damaging of the sensory neural. Conductive, you stick a fire truck in your ear, you got too much earwax, or you're trying to clean your ears and you poke your eardrum. Trauma could be both. Genetics could be both. Probably a little bit more sensory neural. And then infections could definitely be both, right? We have otitis externa, otitis media. It can move through the eustachian tube if you have an upper respiratory tract infection, but then it could also cause labyrinthitis and disturb the cochlea and the vestibular system. So how do we tell whether you have sensory neural or conductive hearing loss? There's the Weber test, and so here we're going to put a tuning fork on the top of your head, and it's, can you tell us Weber, the right side or the left side is louder? So we're going to play this, see which one is louder, left or right side. And then we have the Rinne test, and I think so. Remember the auricle of the ear, the outer ear is called the pinna. I think the pinny, and so it's the Rinne under the pinny. Is how I remember. First, we ring it. Notice that this is outside the ear, so this is going to be testing air conduction, and then we're literally going to press it to, like, I guess the mastoid process or somewhere in the temporal bone, and the sound's going to move through the bone to get to the inner ear, and so this is bone conduction. So you do the Weber test first, and here we're just seeing, probably someone that realistically we know if there's a problem, and we also know which ear it is because someone comes in and they go, hey, my left ear can't work, or both my ears don't work. But in this theoretical NBME scenario, this is how it's going to happen. We don't know if there's a problem. We don't know maybe which ear there is. So maybe you have an elderly patient, right, where there's an issue with communication. So we do the tuning fork, the Weber test. Can you tell us if this side is louder or if this side is louder? If both sides are equally loud, you're fine. Or technically you could be screwed if both sides are equally quiet, but we'll just assume you're fine. If one side is louder than the other, that's going to be the scenario. That's where there's an issue. Now we know something's wrong, but we do not know if it's sensory neural or conductive, and that's confusing, and it's really important to understand. Let's say that this side is louder. Actually, no, let's say this side is quieter. That could mean that there's sensory neural loss. So just like the nerves here aren't working as well. So it doesn't matter if sound's coming from the outside, and it doesn't matter if sound's moving through here. The issue is that we have a damage to the nerve there. That's why this person's left ear will be quieter. So sensory neural loss makes sense. It would be quieter. The kind of more confusing one is that it could actually be that this side is louder and this side is quieter. It actually could be that the louder ear is the one where we have the hearing issue. It could be conductive hearing loss. Imagine that you just got a bunch of earwax, or you got a fire truck stuck in this guy's ear. A lot of the air tries to come in from the outside. It just can't get through the external ear, and can't to be processed by the cochlea and the sensory neural system. So that's why this person's not hearing out of the left ear. But when we do the tuning fork, it's going through here, moving through the bone, and it's bypassing the external in the middle ear, and it's hitting the sensory neural. Okay, well, you might think, well, okay, they could hear then, but like wouldn't be, why would it be louder? And it's because you always have sound coming in through your ears, and if several people are talking at once, the louder person might kind of like muffle the other person. And so this ear is completely quiet. It's a complete vacuum. So there's no sound competing with the sound coming from here. And so this makes it, because there's no background noise, this makes the sound like tunneling through your bones much louder, because going in this ear, it has to compete with all of this outside stuff, and here there's nothing, and so it's going to sound much louder. Now that we know there's a problem, we want to know if it's conductive or sensory neural. This one's a little easier to understand. Air conduction should always be more effective than bone conduction, right? I mean, we evolved to have sounds moving through the air, not through like vibrations of our skull. So normal, the air conduction. So first we're going to play it once right here, and then we're going to touch it, Rinne under the pinny. So this is the Rinne test, and it's right under the pin of the auricle, and it's supposed to be bone conduction. Bypasses the external and middle ear and just goes right to the cochlea and the vestibulocochlear nerve. So normally this should be loud, this should be quiet. So that's normal. If we have a sensory neural defect, well, yeah, your sensory, your cranial nerve 8 doesn't work that well, but it still should pick up on the air from the outside more than it picks up in the bone from the inside. Because the issue is not getting through the outer ear and the middle ear. The issue is the nerve itself. So it's gonna be quieter both ways, but again, the air conduction should be louder. Now, if we have a conductive hearing loss, again, the issue is that like there's a clot here. So we just can't get the sound through in this case, because again, there's this large obstruction. But if I have this large obstruction, I'm bypassing that, and I'm just going straight to the source, the cranial nerve 8 and the cochlea, and it's going to be processed. And so the bone conduction will be louder than the air conduction if you had like earwax or something. So taking these two tests together, we can then diagnose somebody. If you are healthy, it should be equal on both sides, and air conduction is better than bone conduction. Now, if it's conductive, it's unequal, and we'll figure out whether it's the quieter or louder ear that's the affected one in a second. Conductive, we have too much earwax. The bone conduction is better than the air conduction because you can't get through from the air, but you can get through if we push it to your temporal bone. And in that case, if it's conductive, that tells us then that the louder ear when we did the Weber test was louder only because there is no background noise competing, and so that the sound becomes amplified. So we can later find out whether the louder or quieter one was the pathologic ear. Sensory neural, again, should be unequal, and if we should have the air conduction greater than the bone conduction, because it's not the issue of getting in, it's the issue of being processed. So getting in is not an issue. So air conduction is still better than bone conduction. And later then we can figure out, okay, when we did the Weber test, it was the quieter ear that's the affected one. Vestibular system. All right, so we have the cochlea over here for hearing, and then vestibular system now is for balance, vertigo, and whatnot. So here are semicircular canals. We have these enlarged ampulla at the bottom here. Then we have the otolith organs, the utricle and the saccule. And so the semicircular canals, we have these three little canals going in all of these different, the X, Y, and Z plane. And so if someone shakes their head, yes, like this, back and forth, that's going to stimulate fluid to move through this semicircular canal, which is, they're sensing the acceleration here and the rotational motion. And that's how you can tell when you're nodding your head. You can feel it. It's physiological, right? And then if you're, I touch my head to my left shoulder, and now I'm touching my head to my right shoulder. The head's moving in this particular direction. And now we're stimulating this semicircular canal. And here we're shaking your head, no, I don't want to take my NBME. Now when we're shaking your head, fluid is moving through here, stimulating hair cells, which are going to cause action potentials, which go to the cerebellum in the brain to let you know where you are, what you're doing. So a lot of this is going to be connected to the eyes. So as we're moving the head left to right, the information from these semicircular canals is going to contribute to the vestibulo-ocular reflex, very much like the lateral gaze reflex, where the FEF goes to the PPRF and the MLF and whatnot. But notice that as this person turns her head, she's keeping her gaze. I screwed it up. She's keeping her gaze completely central. I shouldn't have drawn on it, but you can see what I mean. She's keeping her gaze completely central regardless. And you can do that right now. Look straight ahead. Keep looking straight ahead. Pick an object. I'm looking at some bananas on the table, and I'm rotating my head to the right, and I'm still looking at the bananas. It's kind of amazing that this reflex is just automatic. You don't really have to think about this. Input from the semicircular canals allows this to happen. I don't think you necessarily need to know the whole pathway here, but you should know it works very similar to what we saw earlier with the, when you have a lesion, you have the internuclear ophthalmoplegia. This is very similar to that. Okay, so again, we have these, X, Y, and Z dimensions. We have the ampulla, and it's as we're rotating our head or spinning or something that we're going to have the endolymph in here flowing, and it's going to stimulate these hair cells, which is going to, let us know that we're moving our head and help with balance and the, vestibulo-ocular reflex and whatnot. So away from the semicircular canals, we're now looking at the otolith organs, which are the utricle and the saccule. The utricle is for horizontal movements, and the saccule is for vertical movements. These are mostly picking up on acceleration. So if you're accelerating like this guy, Brad Pitt, in the horizontal direction, this is going to be the utricle. We have these little calcium carbonate stones, these otoconia, and they're just sitting on top of this. And if you accelerate forwards, this is going to move forwards, and these hair cells are going to pick up on that movement and send messages letting you know that you're accelerating. It doesn't just do acceleration. That would also just tell you this is not acceleration, but if you just, here we're upright and the otoconia are just sitting like that. And here we have our head tilted forward. If you just tilt your head forward, and you close your eyes, you can still know, the proprioception, you can just tell that your head's tilted forward because the otoconia gravity is kind of bringing them down a little bit, and that's bending the hair cells, sending signals. And it's kind of like these little, I forget what these are called. Ghost bubble. It's a ghost device. This a little bubble balancing device. It's similar to this with the otoconia shifting to the left or to the right to let you know if you're in balance. All right, vertigo. So vertigo is when we have a mismatch between vision, proprioception, and vestibular systems. These are our big three for balance and just feeling normal, honestly. So vertigo is you have a sensation of the room is spinning even if you're not moving. You might also have nausea and vomiting. So vision, proprioception, and the vestibular system all are going to the inputs to the cerebellum. The cerebellum is the nucleus, which is integrating all of these things and making sense of it. The proprioception from the dorsal column and the medial lemniscus specifically goes to the vermis in the center, which is the spinocerebellum. And the vestibular system and the vision go to the vestibular cerebellum down here, which is the flocculus, also known as the flocculonodular lobe. Remember that the peripheries are for like, I want to do a penalty kick, let's do a planned coordinated action. So that's not as involved. So there's two types. We have central versus peripheral vertigo. Peripheral is mostly going to be the stuff with the ear, and central is going to be a little bit more pressing. It's going to be like you have an issue with your brain. So this is going to be the vestibular system is not working. We have benign paroxysmal positional vertigo, Meniere's disease, vestibular neuritis, and all of these are going to present with either a horizontal nystagmus or a torsional nystagmus. So here's our horizontal nystagmus. You can just kind of see the saccades as the eyes are going to quickly jerk left, right, left, right, left, right. And here, more complex, like kind of like up, down, left, right, like diagonal movement, is this rotary nystagmus. So this is going to be peripheral. And it's usually positional, not Meniere's, which we'll get to. So that means like if you lean my head back, that's going to induce the vertigo. Auditory is usually affected because you know what? The vestibular system is right next to the cochlear system. The exception is BPPV. Central now is brainstem or cerebellum, like lesions or tumors or whatnot. So we could have an ischemic stroke. The cerebellum, obviously integrating these three inputs is going to be important. The SCA, AICA, and PCA are all going to cerebellum, cerebellum, and cerebellum. The lateral pontine could be the AAICA. Remember, this is a little bit more sound, but the more common one is the pica. And I remember the medullary in Wallenberg, just so you know that name. This could also be an issue. Cranial nerve 8, despite the rule of 4s, is kind of in both territories. Multiple sclerosis could demyelinate something, causing a central vertigo. And you could get a vertical nystagmus where you have these kind of like up-down saccades. I couldn't find as many GIFs of that. Auditory is usually not affected unless there's like a brainstem stroke. And again, AICA, is, despite PICA being more common, AICA is going to be more common for like an auditory issue. Wallenberg will affect the vestibular system a bit more though. And it's usually not positional because it just has to do with the tumor, not like the vestibular system directly. So causes, so we can get these vestibular migraines, which we actually didn't really talk about, but a migraine can actually affect the vestibular system and induce vertigo. BPPV is the most common one, though. I would definitely know that. So when in doubt, BPPV is your best guess. So speaking of which, I mean, it's all in the name. This is benign. It's not like immediately pressing, right? I mean, it's bad, it's concerning, but it's not like you have a tumor and you're going to die. Paroxysmal, it's kind of touch and go. It's hard to predict exactly when it's going to come on. And then positions make it worse, and you have vertigo. So the otoconia from the otolith organs, like the utricle saccule, they actually dislodge and make their way into either the ampulla or somewhere in the semicircular canal. And we see it right here. And so as you move your head around, nod left, right, up, down, touch your shoulders with your head, this can move the stone around, stimulating the hair cells and blocking flow. And again, you can see this rotary nystagmus. Again, vertical is going to be for the central. And it's very, very positional because as you move around, you're going to move the stone. So the Dix-Hallpike maneuver can diagnose it. So you're just going to take a patient back and then sort of lean them back at this nice 45-degree angle, hold them there, and then the vertigo should be induced. To get the stone out, we have something called the Epley maneuver. So we take someone, we lay him down at a 45-degree angle, wait for 90 seconds or whatever. Turn over to another 45 degrees angle on the other side, and then you're going to rotate their whole body, though, is staying still, but now you're rotating the entire body 90 degrees. And that should get the evil demon, the sucker, out of the semicircular canal with those movements. So vestibular neuritis, also known as labyrinthitis, remember this is an inner ear inflammation, usually following an infection or during an infection. It's typically self-resolving, and it could be positional, but because it's the inner ear, the labyrinth, it's probably going to affect the hearing and the cochlea as well. Meniere's disease is excess endolymph, and remember that big ugly side, we had the wave pool, we saw that there's a lot of endolymph that is moving in the cochlea in response to the ossicles banging against the oval window. And that, the movement of that is going to stimulate the basilar membrane and the organ of Corti. So if we have too much endolymph, is too much the endolymph in both the semicircular canals and the cochlea, this fluid buildup can cause vestibular and auditory symptoms. So it should make sense that it's both. It could be hearing loss, or it could be kind of the opposite. It could be tinnitus, you're hearing ringing, and then vertigo. Again, too much endolymph in both of them. See how this is swollen and this is less swollen. It's not positional because it's just you always have too much endolymph regardless of which way your head is sitting. So it's just creating too much pressure, which causes all the effects. A diuretic is going to, you You're going to have less fluid, means less generation of this endolymph, and it can cause the levels to go back down, hopefully. So moving from peripheral to central could be a tumor, could be causing your central vertigo, probably an acoustic neuroma or something. Strokes, we said the AICA and the PICA. We should be familiar with all of the symptoms at this point. Romberg. So the Romberg test is going to diagnose this. Well, actually, it's more going to diagnose proprioception, which we'll get to. So as we said, here's our body posture. Here's us not having body posture is good. No truncal ataxia. We don't have vertigo. And this is the proprioception, one, the vestibular, and then the vision. All three of these are integrated in the cerebellum. And when we have all of this working well, our body posture is fine. If you imagine that I take away the cerebellum, well, what's going to happen? If you just think of the physics of this is going to fall over. What if I took away one of these legs? If I take away one of these legs and now I just have this one and this one, it still might be enough to counterbalance this large cerebellum. And counterbalance maybe isn't the best analogy, but that's just the one I found online. But if you would take away two, now it is probably going to fall. So the point is, you take away the cerebellum, you're going to fall. And you take away two of these. We have 1, 2, 3. You take away two of them, then you're going to fall. You just need 2 out of 3 to be fine. So again, vertigo, the mismatch between the sensory inputs between all of these three systems. You just need 2 out of 3 to be normal. So the Romberg test. First, we're going to ask you to just stand there. And if you are, excess swaying or loss of balance, even when your eyes are open, then we're going to say that you have a cerebellar issue. Your cerebellum isn't working, your eyes were open and you fell. It's probably going to be the fact that the problem is that you just can't integrate these things properly. Now, when your eyes close, then you have balance issues. That is said to be a positive Romberg's. And if you close your eyes, you're taking out vision. So what do you got left? You got proprioception here, and you got the vestibular system here. So for the most part, this is used to diagnose proprioceptive dorsal column medium lemniscus things, right? Maybe you have like tabes dorsalis, tertiary syphilis, and you don't have proper inputs to the to the spinocerebellum of your brain. This is going to cause an ataxia. So this is to diagnose proprioception. I don't know why that this is not as much used to diagnose vestibular, because as far as I'm thinking, if you close your eyes again, you have this one and this one. If you have a defect in the vestibular system, you should also fall over as well. And maybe it is sometimes, maybe it's the fact that the most common vestibular system is BPPV, which is, as the name implies, positional. And so if you're just standing, you're actually not triggering the vertigo in this way. So the vestibular system is intact if you're just standing there, as opposed to like you're bending your head over. That could be one answer. Maybe there's other things that I'm just not aware of, but I would definitely know the Romberg. So eyes open and you fall, cerebellar issue. Eyes closed and you fall over, either a proprioceptive issue or a vestibular issue because your eyes have been taken out of the equation, but for whatever reason, it is more diagnostic towards the proprioception. Okay, cool. That is it. Thanks everybody for watching. I hope y'all kick ass this upcoming week. Hope everyone's doing well. All the best.